Welcome, everyone. Welcome to the PACIO integration track at the HL7 Connectathon 38. Huge shout out to the large number of people across multiple time zones who have done so much work to make this track possible. Clinicians, technical folks, just an awesome group of people to work with. So really appreciate that as a personal note. Got a lot to show, so we're going to dive right in. Our patient is Jenny Mosley. She is a 68-year-old African-American woman. She is widowed and has been retired for 4 years. She has a medical history that includes depression, anxiety, hypertension, hyperlipidemia, and a 20-pack-year history of smoking. She has a significant family history of cancer. She has a maternal aunt who had ovarian cancer at age 69, a sister with breast cancer at 64, and a paternal uncle with pancreatic cancer. All of them are currently deceased. During a routine screening mammography in February 2018, an abnormality was detected, and she began a complex process of testing, pathology, and staging, which resulted in a breast cancer diagnosis. She prepared a Washington State Advanced Directive to guide her care as part of her response to this new diagnosis, and she was treated with chemotherapy, surgery, and radiation, which was a grueling course of treatment, and afterwards her cancer was declared in remission.
So we're going to be reviewing Jenny's history. We can see that she is about a 69-year-old woman. She's African American. She lives in the state of Washington. Her primary language is English, and she has a brother, James Mosley, and a good friend and advocate, Rosemary. I'm going to skip around here and give you a quick overview of her background and then dig into some of the other aspects. So she does have an allergy. She's allergic to penicillin. She doesn't have any current immunizations. If we jump down to her procedures, we can see that she had a mammogram in 2018. And unfortunately, it was time for more investigation. She did have a biopsy at that time. And in fact, after that, she had a partial methectomy. So this is her first encounter with cancer. And you can also see, just giving you a little bit more background about Jenny, she has several people in her family that have also had a history of cancer. So she had a maternal aunt who had a malignant tumor at the age of 69. Her sister also had a breast neoplasm at the age of 64. And she has a paternal uncle who also had a malignant tumor of the pancreas. All right, so with that, I'm going to jump over here to her conditions. And you can see that going back down here to 2018, she does show that she had this malignant partial mastectomy, but in fact, her cancer was in remission in that area. I also want to jump down to her lab results. So you can see a couple key points here. So on 316, so these are various staging markers, which are indicative of her past history of cancer, and also this HER2 result. And you can also see here, we have these biomarkers. You can see the various results of all of that. Additionally, if we go back to here, we have her breast pathology report from the time when she did have her mastectomy. So all of that information is available. And all of this together, factors together to really inform the clinician the extent of her disease, of her breast cancer, and it helps to inform her chemotherapy treatment, as you'll see in subsequent stages.
Maria and Lisa are going to demo the baseline advanced directives and MyDirectives for clinicians.
Super, thank you very much, Howard. I'll just show you through the front end of the screen because, in HL7, the magic really occurs in the metadata and the document exchange. So this is MyDirectives. We are logged in as Jenny Mosley. And disregard some of this, as you know, we've got layers and layers of work that has been done. Here is the baseline Washington Advanced Directive. It does show an initial create date of 2/18. It does show an update date because I've already deleted it and restored it. That is Jenny's documents. And Lisa, I will go ahead and turn it over to you for the metadata because you can harken back to the original iterations of the documents where I'm challenged by that.
The MyDirectives for Clinicians system that Maria, or just MyDirectives for that consumers use, those are our client apps that are a part of the MyDirectives whole solution suite. In addition to having the technology that allows people and clinicians to create these documents, there's also a registry, a national registry that's part of the solution, so that once documents are completed by people, if they're writing them themselves or when working with physicians to create portable medical orders, provider-authored documents, then those finalized documents live in this national registry so that they're accessible not only by the MyDirectives solutions, but also by any system that can be querying the registry through national networks and other APIs. So I'm just going to do a quick query. We have just a couple of patients that we're working with here at Connectathon today. And I'm going to show you what's been sent to the registry so far in the story for Jenny Mosley. This is the completed, you can see that the registry status, this is like the card catalog system of the registry. I'm looking at the index card that is the one that's current. And this is indexing the document, which is a finalized version of a Washington Advanced Directive, version 1. This is its standardized document type code. The registry utilizes a hierarchy of advanced care planning documents that we've worked closely with Regent Streif and HL7 through many implementation guides focused in this area to establish a relationship between standardized LOINC codes that tell you what types of documents and how they roll up in a classification system that allows you to know broader kinds or categories as well. So this is the standardized code part. There's document identification number. I'm showing the set ID and version number, the date that the document was created, as Maria said, February 18th, 2018, authored by Jenny Mosley. The next thing I'll show is just a quick examination of the resources. This is a FHIR document server. Right now we're demonstrating the management of the life cycle of a particular kind of or class of documents, all these advanced care planning documents, but it's built on the basic premises of document management in FHIR. And so the document reference resource is that card catalog resource that's keeping track of each and every document that's written to the registry. And a couple little key things I want to show about this. I've been playing around with some evolution in the area of contained resources. As we've been implementing this in the field, it is an interesting thing to understand, well, what resources really want to be written to Epic or Cerner or Meditech, and which ones should be contained resources because they're not going to be written out as live resources on the other system. And so this one is just demonstrating that we've shown how the endpoints of the custodian resource. So there's two endpoints listed for this. There's the endpoint that is how you get to the AD Vault Exchange via FHIR and the different formats that are available on the FHIR server. And then there's the endpoint for how you get to the MyDirective server as a query responder in the Care Quality eHealth Exchange networks, and again, the formats of documents that are available in the registry. So those are contained resources along with this organization resource that is telling you who the custodian is. Down here in the main part of the document reference resource, there's a couple of extensions around identifying the document. Here's your status of this record is current. The document status is finalized. Here's your type code, which you saw earlier in the user interface. And here are those categories that can basically tell you that this kind of document, which is a combined living will and medical power of attorney, rolls up to personal advanced care plan. It's one of those kind of patient authored documents. And ultimately, they're all in the space of advanced healthcare directives. Here's your subject, your author, your custodian, that's referencing that contained resource for the custodian organization. And then this area is where organizations that query for the documents can get a sense of what's available. You know, is it available on video? Is it available on hard copy? Is it available, whatever? All of these sets of content attachments tell you the story of what's available. So here's one option. You can pick up a binary resource that is the CDA document, CDA plus XML, and it's from the PACP structured document IG. Another option here is just a straight up PDF. There's a FHIR document, a binary of the application FHIR plus JSON structured document. And then we have a couple other easy ones. Here's the live bundle that you can look at. I use this a lot for debugging and also for quality testing. Sometimes I just go straight into the composition. Probably not relevant from a registry point of view, but I just wanted to show you the power of document reference in that it can serve up the same document in many different formats, so that no matter what your application is ready to consume, we've got something that's the right fit for you. If all you can handle are PDFs, you can grab the PDF. That's what was the source document that was filled out by Jenny. If you're ready to pick up a structured document with some metadata, then you can pick it up as a CDA, which includes the source form and then all of the structured data of the header. Or if you're ready for a FHIR document, the bundle with first resource, bundle of type document, first resource composition. This isn't a great viewer yet. I'm working with the IPS guys to see if I can borrow theirs. But this will someday be a nice rendering of the FHIR document itself. So this is where we'll come in the scene, so you can see document management over time. Next time we visit, you'll see some activity with documents that are changing state, versioning, being revoked, etc.
Awesome, thank you. We're gonna go back to Nancy. We need to show the medication list.
And so we see here at this point in time, we can show her completed course of therapy. So we can see that in 2018, we mentioned a little bit earlier, she was treated for breast cancer. And you can see this various levels of meds that she received at that time. Again, this is a completed course. And then at this point in time, this is her home medication list, the start of our story. Thank you.
Awesome, thank you. All right, next up is Justin with the baseline advanced directives.
Thank you. So what you're looking at here is the WA Verify Plus patient electronic health record, which implements the International Patient Summary. And I've pulled that down for Jenny Mosley. And what I'll do next is add advanced directives to it from the AD Vault server. So I'll do a search here and find those and let that spin for a couple seconds, and then we get our first advanced directive down there, and we can see details about it. It is still current. We can view the PDF as well, which looks very similar to what Lisa just showed. And that's it at this stage.
Awesome, thank you. Juby and Colleen demo the baseline advanced directives in PyConnect Health.
You can see that there is Jenny and her advanced directive. I will pull up the PDF version. I'm going to scroll it down to show. Here we are, and we have it also here, and that's where we are.
Awesome, thank you. Kaylin, please demonstrate baseline data with the PseudoEHR.
All right, so I'm going to show the PseudoEHR reference implementation to demonstrate the resources available for Jenny M at this stage. We have Jenny's personal information displayed here. We can also look through each section resources. So we have conditions for Jenny displayed as a list here. For example, anxiety disorder, have details of, for example, the provider. We also can demonstrate the medication lists at this stage. And so there are two of them that you can see in a list here. So one of these is a discontinued medication list. Another one is her home medication list with the medications themselves. We can also look at the list of medication requests for Jenny. So you can see here, these are the requests by the different medications and details about that medication request. And so I can also see procedures for Jenny displayed, for example, here. So you can see procedure code and more details about that procedure here. All right, and last thing that I will share for this scene is looking at the observations. So if we take a look at the observations, we can also see the assessments done for Jenny at this stage.
Awesome, thank you. 6 years later, in July of 2024, Jenny began experiencing early morning headaches that gradually increased in intensity. She also experiences some trouble walking. On September 21st, she presented to her primary care provider for an appointment, and the primary care provider was alarmed by these symptoms and findings and advised Jenny to go right to the emergency room for an MRI and CAT scan. Jenny presented to the emergency department that same day and has an MRI and CAT scan. The MRI reveals multiple metastatic lesions. Her chest and abdomen CT are clear. Because she does have problems with ambulation, that's walking, and does not have family or friends capable of taking care of her at home, she was admitted to the hospital for further testing and preparations for treatment. The hospital proposes a plan of care that includes chemotherapy, steroids, estrogen antagonists, and medications for symptom management. She easily met the criteria for initiating this treatment, and prior authorization is granted.
All right, so for scene 1, we should see that there is a new medication list here for Jenny. And so we can see that her previous medication lists are down here. The new one is the hospital administration list along with these medications. We can also take a look at her medication requests. There are now 17, and so we can see these listed here. So the same details displayed for the medication request. And also, I think in this scene, we also have a nutrition order that we can display. So this is a nutrition order, oral diet, and details about that also.
Thanks very much. All right, and as a refresher, this is the recurrence of her cancer, and she went to the doctor who sent her to the ER, who got some testing done, and now she's been admitted to the hospital in preparation to kind of get to the bottom of what's going on with her headaches and her trouble walking. And it looks like she has metastatic lesions in her brain, and now she needs cancer care. And so next is going to be Juvie and Colleen with the prior authorization demonstration.
So this is Jenny's basic history, and then we're going to go into the prior authorization for her chemotherapy. So when you do that prior authorization, there's going to be 2 types. There's one for the drug, and there's one for the actual administration of the chemotherapy. So there's coverage requirement discovery. Does the patient have the coverage? Does the patient need to have prior authorization? Does she, is that an active insurance? All the things that usually is called out or by phone, that takes a lot of time, only, requires a few seconds. And this is connected to the backend to the Cambia regions. So for this particular one, we can choose chemotherapy or biologics because technically both are going on. So I'm just going to start with chemotherapy. And so a response came back saying that it's prior authorization needed. It's conditional. So now we need to go look at what that conditional is. There are 2 ways it will go. One is it can go straight to prior authorization, which has a set of documents already preloaded or preset that will, under the Da Vinci protocol, it will go directly to Cambia's endpoint, which is prior authorization right there. But for this purpose, there's the Milliman guidelines and other types where you usually have to go to a medical director manually. You need to go through this DTR process. It's a conditional. So that means you need to send additional more information. A lot of times you kind of know what it is, or they will let you know. And right now, the answer is we have to fill out this form, the additional prior authorization form, and send it to them. And once you send that, you'll get a response back saying that it's approved. So the thing that we have to realize, this is what it makes life a lot easier, when you are inside a physician's office or setting, just make it biologics. Okay, so we got that. So under the highly complex, we got an approval that says it's covered. No additional authorization is needed.
Thank you. Jenny begins chemotherapy in the hospital on September 25th. On September 26th, she meets with her case manager who facilitates creation of an advanced care plan and portable medical order. He also advises revocation of Jenny's Washington State Advanced Directive, as Jenny's goals, preferences, and priorities have changed since it was created 6 years ago. Jenny has near immediate unpleasant side effects from the therapy and from the cancer, including nausea, vomiting, pain, and mucositis, mouth ulcers, which are painful. Because her overall condition is stable, that is, her symptoms are well managed and her vital signs are good, her hospital team works on obtaining a Medicaid waiver for her to stay long-term at a skilled nursing facility. She will require limited nursing care, medication management, transportation, and rehabilitation support. And on October 2nd, she is discharged from the hospital. Maria, you're up with create, revoke, and create.
You betcha. Thank you, Howard. What I can show you in this particular screen view, this is our MyDirectives for Clinicians app. I am logged in as Rudy Branch, who is the case manager at the Puget Sound Cancer Center. You can see that Rudy has already been doing a lot of work with Judy Mosley. So what I will show you from the front end is that the first iteration of the advanced care plan, the first iteration of the portable medical order have already been superseded by the later iterations. Lisa Nelson's going to be able to show you that historic data. But I thought what I would do is at least show the revocation of the Washington State Advanced Directive, which was recommended. Once that revocation is applied, that form is no longer a part of the active document set. And so I wanted to just at least show how that occurs. And then, Lisa, I'm going to have to rely on you for the metadata because in our application, it's going to show you the current documents and they've already been superseded. So let me turn the screen share over to you and you can peel back that onion to show the metadata in the original state.
Will do, Maria. Here we go. Back in the registry, let's just walk through the updates that Maria just completed. We'll take a look at Jenny Mosley here, and in the back end, you can see that there's a bunch of activity on September 26th. Here's that Washington Advanced Directive, and you can see now that it has a revoked status. It has been canceled. And this was the document that was originally entered the registry, created on February 18th, 2018. So it was there for quite some time. And now, as of September 26th, it's been revoked. You can also see that there is a new finalized personal advanced care plan document. You can see the alternative type here. This is a more general expression of healthcare agent appointments, care experience preferences, and treatment preferences. And this was created on September 29th by Jenny. And I think I'd like to just show this. So this is a document, as Maria was talking about. You saw in MyDirectives for Clinician that Rudy Branch, the RN registered nurse for oncology, was working with Jenny to support her in authoring this document. She's now made some choices about healthcare agents and appointed people who could speak for her. And then she's provided guidance that if they ever needed to make decisions on her behalf, these are some of her treatment intervention preferences. She's got some care experience preferences, end of life preferences, treatment goals. You can see other more instructive feelings on things that might be helpful to those agents if they have to make decisions for her. And then signature pages, signing information, etc. So this whole document is available in the registry. And as Maria said, it is available with all the metadata that basically tells that story of the data provenance, the source form, as well as structured data about the healthcare agent appointments, so that if a system was able to import structured data, they would be able to pick up who those healthcare agents were, how to get in contact with them if they needed to contact them rapidly. And then you can see here, portable medical order was crafted based on those wishes. Rudy and Jenny were working together and pulling a medical order together that ultimately was signed off on and listed as authored by the licensed provider, Owen Oncologist. And I'll just start right here with the structured data so you can see the source form and some of the structured data. You can see Jenny's now got an order in place so that if she were to be picked up by an EMT, this is the yes CPR aspect of the order, attempt resuscitation. So she's giving the signal that she would want first responders to resuscitate her. And she's got full treatments for her initial treatment orders and some additional instructions that are documented narratively. You can see it's important to be able to see the form, gives people a lot of confidence that they understand what it is that they're working with and looking at. And then if I close the source form section, you can see here that all of the whole portable medical order information is also contained in this document in a structured way. So each one of those service request entries that they turn out to be in FHIR have been provided as machine processable and human readable structured data. Again, the FHIR rendering of that is not as mature. It looks a little bit better here, but the source form, which is the first section in the composition that's inside that document bundle, it has a single entry that's a binary resource. That's what brings up the PDF. This is the narrative text A through D, kind of just giving the humans a sense of what these 4 entries in the document are presenting. There are 4 service request resources representing those orders and some of the demographic information about Jenny. So this is all set up so that when folks query the registry, they have the ability to pick up the current documents. And in picking up this one, it should be communicated to anyone receiving documents. If they had this previous Washington Advanced Directive document, they should know now that that was canceled as of September 26, 2024. And we'll be able to see next if our clients can discern that when they pick the resources up from the registry.
Thank you. Very cool. Next is Justin with changes in advanced directives.
Thank you. So here we are back at the Verify Plus Washington State application. And again, I have the patient's data already loaded here, and I will retrieve the current advanced directives and add them to our international patient summary. So scroll down here and we'll see the ones that Lisa was describing. So first off, start with this canceled one here. As Lisa noted, that one has been canceled. Then we have 2 new ones that include structured data. So looking at the post, specifically structured data regarding performing CPR, full treatments, additional treatments, etc. And of course, we can view the PDF as well. And that's that.
Awesome. Thank you. Juby and Colleen, demo advanced directives.
So we're going into the version 1, canceled one, showing this as canceled, 926. Okay, then the version 1 that is now active. Pretty much the same as what Lisa was showing, with the Rudy branch as the signature. And showing the witnesses. You have the summary. It's got the PDF reference back to it. And then there you go. Portable. medical order. We have Jenny Mosley's portable medical order that shows the CPR, full treatment, signature. Here it is. I believe the practitioner's contact information is also very clear so that you can identify that.
Thank you. That same day, she is admitted to the skilled nursing facility. She takes a ride right from the hospital to the skilled nursing facility. On October 3rd, she meets with an admission coordinator and a clinical social worker within the 48-hour window of her admission, where part of the process involves a review of ACP documents. When Jenny is asked if these documents are still consistent with her goals, preferences, and priorities, Jenny says no, which cues the admission coordinator to facilitate updates to Jenny's ACP along with creation of a new portable medical order to inform the care she receives in the skilled nursing facility. Jenny continues chemotherapy while in the skilled nursing facility. During this stay, her pain worsens and the ulcers in her mouth continue to be her most unpleasant side effect. The skilled nursing facility practitioners continue to assess and support all aspects of her care. She receives a diet that is more comfortable to eat and provides her with the right nutrition. She has ongoing functional, cognitive, speech, language, cognitive communication, and swallowing assessments performed in addition to standardized skilled nursing facility assessments, such as the MDS, the minimum data set. Jenny continues to want curative therapy, but complains of increasingly intolerable side effects. And on October 23rd, the care team feels they need expert assistance in managing her symptoms.
Great. Thank you, Howard. We have already revoked the advanced directive, as I shared with you in the prior screen views. And what I've gone and done on this side is to take you into MyDirectives, which is our consumer-facing platform. Look, nothing up my sleeve. That Washington State Advanced Directive is now missing from Jenny's view because she worked within the Puget Sound Cancer Center to go ahead and revoke that, so there was less confusion. You can see that as a part of her skilled nursing facility stay, within 24 to 48 hours of admission, she has gone ahead and updated her advanced care plan to reflect her changing goals, preferences, and priorities for care experience and treatment intervention. So I just really kind of wanted to show the consistency between what the clinicians and practitioners see and what the individual themselves is able to see. These are the updates that she has made to those documents, and they are clearly visible. They can be downloaded, they can be printed. And again, I don't want to spend a lot of time taking a look at this because really it's the magic in the metadata that matters more than anything else. But here is the 10-3 update. Sorry, that's her date of birth. So there are the updates that have been done, and you can see that these documents have been updated. And I just thought it would be interesting to show the view, not only from the clinician side, but from the patient side. So Lisa, I'm going to swing it over to your extremely important view of what the registry does in the metadata.
One of the most important jobs of the registry is to make sure that everyone who needs access to Jenny's documents has always got the ability to get the most current version. And that's why I'm just kind of focusing on showing you how the registry keeps track of all that. So in this case, based on what Maria was just describing, that earlier portable medical order was canceled on October 3rd because a new one was created that reflected her new views. And I like when you can see it here and then you can immediately see what the clients are getting, all of the updated information. So here's that document as of October 3rd was canceled. And then a new order right here was instantiated by Joseph Yazer. And this has just got the changed information. Orders are never versioned. They're always canceled and new orders are created, as opposed to the Personal Advanced Care Plan, which is a patient-controlled document and something that can continue to version over time. And so here, looking at the active one, you can kind of get a picture of that document going from the earliest version, which was first created on September 26th, the second version completed on 10/03. And you can see that they are logically linked together because they carry the same set ID, and yet they have different version numbers based on temporally when they were created. And now this current one has the source form as well as, again, structured data on who the primary and first alternate healthcare agents are. I wanted to just take 1 second to talk about something interesting that the registry is doing that you won't hear about in any other FHIR tracks that are going on right now. I want to talk about digital signatures. And so there's work that's going on at HL7 talking about what needs to be our digital signature strategy. And I wanted to show that as these documents enter the registry, we are sealing them with a digital signature. And that digital signature information lives in a separate document signing page. You can find them in the document reference in the card catalog file, looking for authenticity information. And it's both the type and the category. It's very narrow right now. We just have this one kind of digital signing page that you can find. And then you can see that this metadata in here tells you what the relationship is to the document that this signature page signs. So its relationship to the source document, which is referenced by this, is that it signs this document. And then it carries the signature hash that is created, that is content type application JWS, following what's a process that can work for not only files that are expressed in JSON, but XML as well. And so this is a process that could be used to sign the CDA documents that come into the registry as well. Right now, we're signing those with a different X80s technology that comes from the digital signature spec that only works for CDA documents. But why use 2 separate ways of doing it when one process could really serve the digital signature needs of all kinds of documents? CDA, FHIR, even V2 resources could be signed this way. And with that, I'll head back to our next client who will draw from the registry.
So back at our application, and I'll pull down the latest advanced directives for Jenny. And we now have four down here. The first has been canceled, and we kind of watermark that there to indicate that. We also have a canceled post here. The personal advanced care plan, the current one, and the current post, also showing the structured data.
Thanks so much. Juby, you are up with advanced directives.
It's canceled as of 10/3. Okay, maybe just go to the new one. Shows this is a get the date of 10/3/2024. And it's giving the name of the person who's assisting for the winkler and PI reflected. So you have it here, but it's very easy to capture whoever you need to contact if you need. See who originally signed the document.
Awesome. Thank you. All right. Next is Nancy with ELTSS care plan and care team.
So I'm going to start by creating a care team. And we actually have quite a few members of the care team for Jenny at this stage in her progress. So I won't bore you with creating all of them, but I wanted to give you an idea of how this works. So what we're doing is we add participants. We can either add them manually, or we can go ahead and search in the directory. If we have information in the directory, that's a much faster way to go rather than trying to collect all the relevant details for each of our providers. So I'm going to start by just searching for a few. So let's look for Dr. Park to begin with. And here we see we have all of his information, and so we could add him to our care team. I'll add a few more as well. So this is her oncologist. We'll go ahead and add him as well. And we'll add just two more. We need her physical therapist, who's Luna Baskin. And we think we want the Luna Baskins that's in Washington State, so we'll choose her. And one more, we'll find Jed Cadbury. And obviously, we could be searching by a lot of types of fields, by organization, full name, by specialty, or simply by address. And again, we'll choose the Jen who's located in Washington. And so this would continue until you kind of built up her entire care team. And I think folks have found that having a complete care team, and we know who our patient's seeing for what purpose, really helps to understand, A, who she's seeing and who to call as her needs change over time. Additionally, with their care team, we can make a notification. We can either notify her entire care team or subsets of her care team, and we can send an email, with a subject and a message. So, for instance, perhaps we've updated our care team, or perhaps she's been readmitted to the hospital, or some specific event. We want to notify other folks to kind of be involved in the care. We can send a message off. So that's how that works. And then yesterday we had a breakout session in creating a care plan. And this is the care plan we created using this particular tool. I'm going to go back and use this tool again, showing how we can change that plan. But for now, I'll show how it looks when you're sharing it. So if anybody on the team or anybody who has access to this data can see where Jenny is at this point in time. So that we can see that when we look at her strengths. So at this point in time, she's mostly independent in her function. She's demonstrated a high degree of determination to achieve her goals. She understands her life-limiting condition. She has certain preferences, so she'd really prefer to be home as possible. If we were doing the full story here, we'd also see some assessments, and we'd learn that indeed, she would be living by herself, and she needs certain care, and she just wouldn't be able to provide that self-care at this point in time. She does prefer to be as independent as possible, and she prefers really comfort over function. So again, just summarizing her personal goal, her goal is to be as independent as possible while she's still comfortable. And again, this is an ELTSS care plan. It tends to be used in long-term services and support. And we really like to focus on the patient goals here. And that very much melds together with what you're seeing Maria and her team demonstrate with the advanced directive. So these are the various needs that we've determined she needs at this particular point in time. She still needs PT and OT for subtle cognitive findings and early interventions. She's still at risk for falls or other kinds of declining function, and she still needs her pain control. I'm going to jump down here to our risk management plan. So we realize that she still has this progression of her brain metastases. She's at risk for seizures. She's still showing increased confusion. She has decreasing memory and decreasing function. So the plan for that is that we'll have PT and OT monitoring for any kind of progression and suggesting any kind of interventions we might need to mitigate the risk as it's needed. So these are the various services we put together for Jenny. So we'll be giving her physical therapy for ambulation, and she'll be getting that 3 times a week, and that will be provided by Luna Baskin. She'll be getting occupational therapy for the same reason. Again, the same time interval. That will be provided by Jen Cadbury. If we had entered her phone and email and contact information, that would be as well. And we'll also be continuing to monitor her pain meds and adjusting them as needed. And again, that's going to be done by Dr. So that's where the care plan is at this stage. And a little bit later, we'll show you updating that.
Anne-Marie, we're doing a medication reconciliation and risk assessment.
Yes, we are. Thank you, Howard. Upon Jenny's transfer to the skilled nursing facility, the consulting pharmacist conducted a comprehensive medication review as part of her admission assessment. Jenny's extensive medical history is informing this pharmacist evaluation. So we're going to go ahead and load the information into the ActualMeds system from the FHIR server. Data has loaded. We see metadata for the encounter here, where she is at, and now we see the information has just loaded into the system. We're able to see active medications, and then of course we're time-bound sorting these on what is also history based on dates and dispense quantity or expected duration of the regimen. So we're going to go through and review each of these. That will constitute modifying or editing notes into each medication, and then also determining the disposition. So for example, the ondansetron, we are going to want to annotate on that that should be continued, but specifically, we're going to note that that's continue for nausea as needed. And keep that in a continue status. We're also going to note certain things that do need to be evaluated based on a calculation of the risk that we'll be documenting in the action plans momentarily. So when we load the medications fresh, we're able to calculate the risk and see that risk, update it. And based on that, we're seeing impact with the alprazolam, the metocyclopramide, and other things where they're having an impact on cognitive status based on anticholinergic burden risk. So a couple of these, we're going to note them as evaluate back to the prescriber prior to documenting our own action plan. So we're going to change the disposition prior to completing the MedRec. Here we see we've changed that to evaluate. There's a couple more here that we want to revise the disposition. And then based on these changes, we're going to reconcile that list. Reassemble a new bundle. And then pause, you're going to splice in the action plan piece here. And so with the action plans we've authored, we're going to reassemble a new bundle with the reconciliation and the action plans documented, which we can see here. Action plans and the reconciled med list with the revised dispositions. Noting here, for example, the evaluate that we just changed. And then we're going to go back and load that bundle of the structured medication list that we've completed the reconciliation on and the PDF summary. And we're going to upload that back to the FHIR server. And that'll give us a complete bundle that we'll then be able to see in the downstream EHR.
Awesome. Thank you so much. Nancy, do you want to display that?
So I was watching it as Amy was doing that, and this is the most recent document that she's just sent. And you can see that everything she just presented is here. So here we have the problems identified. And correct me if I'm saying any of this incorrectly. And this section is, what is this, Anne-Marie?
Yep, that's the
reconciled drugs.
Yep, reconciled med list with the dispositions as done based on prior dialogue. And of course the action plans as well.
Let's see whether or not the meds came down to our server. And here we see the reconciled list coming from ActualMeds per the demonstration that Anne-Marie just completed. Thank you.
That is still super, super cool to me. Next, we have Abby with demonstrating Presto.
All right. Okay, so we're going to shift gears a little bit to a different part of the skilled nursing facility workflow. The minimum data set, commonly known as the MDS, is a assessment screening tool. It's a survey, a form that clinicians fill out often at discharge. There are some other times during quarterly reviews and other workflows that this might be filled out, but it's a standardized form that's basically defined by CMS and that nursing homes are meant to fill out. It's about 30 pages long, and each page has 10 or more questions. So it has like 300 questions, and it can take upwards of 4 or 5 hours to fill out. And Presto here is a utility we've been developing, prototyping, that is looking at both in a burden reduction sense, be able to fill the form out automatically with a couple different tools. One is going to be using Smart on FHIR to fetch from a FHIR server and to match things up that it can. We also are using some large language models to apply LLMs and AI to fill out the questions that can be filled out. And then lastly, we're also mapping to the PACIO PFE observation resources and not just answering the question, but encoding it in the structured data that downstream systems are expecting some of the coded observations for. So over here, you can see the Presto is designed to run. It's a responsive app. It's meant to display on tablets as well as desktop and be tap and touch and swipe and so forth. We're going to display it in the full desktop mode. We could be fetching from either the patient portal or from the EHR. It has the ability to load up a number of different questionnaires. We've split it up into a number of different sections. We're going to do not all of them, but we'll do a few of them to showcase it. For the purposes of the demo, we're going to directly fetch from the sandbox. In production, it would be a Smart on FHIR authentication process, or possibly launch from the EHR. We've just fetched Ginny Mosley, and we can take a quick look through the chart, and we can see the breast cancer, hyperlipidemia, mammography, anxiety, and so forth. So we've fetched the chart, and the most basic part is that you can fill out the questionnaire here. So we're going to add a record. There would be national provider number, nursing home. We're doing an assessment, none of the above. This is a first time. Entry tracking, planned discharge, no. And we'll do female and Jenny Mosley, and we are going to send this questionnaire on to the PACIO sandbox here, and we send it, and we get a 200 response. It was successful. Okay, so that was the first section. We're going to pick a different section. We're going to go to health conditions, and we'll do the cognitive one next. So for the cognitive assessment, yes, we're going to do a cognitive assessment. Jenny was able to repeat the 3 words. She did get the correct year, but she missed the month and the day of the week. She was able to recall sock, queuing a caller. She need queuing, and she got bed. And so she has some modified independence. And we're going to send a bundle. At this point, Presto is taking the LOINC answer codes from the original questionnaire, flowing them into the questionnaire response, and in this bundle, we'll also be flowing those into the observation records also. So we're going to send that along, and we're going to do one more, and we're going to do the health conditions. And this time, we have pain regimen, we have frequency, verbal, shortness of breath. What we're going to do is we're going to use the International Patient Summary and large language models, ChatGPT, to look through Jenny's medical record. We're going to generate a summary that is going to be fed into the language model, and we're going to ask the language model to try to identify any of those questions. So the first step is we've pulled in the problems list, procedure history, and the international patient summary. We are going to prep the international patient summary by feeding each of these resources into the language model. And you can see it counting down as it's coding them up in a format that the language model can question answer from. There are details like tense, future tense, past tense, first person, third person. You want to kind of standardize those. So we've just prepped it. And this is actually like a quite detailed document that could be put into the IPS itself and generate an IPS if you don't have it already. So we go back to here, and now we're going to go to Philbot. We're on the J questionnaire. We're going to go to Philbot. So here's our workflow. We have the patient summary. We have the questionnaire, and it's section J. We're going to prep each of the questions in a sentence that the language model can understand. And for each one of these questions, we're going to send the question and the entire patient summary over to the language model, and we're going to ask it to try to match things up and identify it. So no whammies, big bucks, big bucks. This is always a little kind of like, will work. Different questionnaires get a different success rate. Sometimes it drops the questions, but the ones that it answered 13 out of 25. So we're going to save those. We're going to go back, questionnaire again. The language model believes that there was no non-medicated intervention for pain. It believes that the pain assessment should be conducted. It did not find any information about pain in the record, so it left these blank. It found a prognosis. It did not find a fall kind of injury. So if these are not correct, we have a quality control section here. And in a second version of this, we have the explainable AI, where it provides a section to describe the answers and why it matched those up. We disabled that for this demo because we needed to make sure that the questionnaires were flowing to the downstream systems, and in future demos, we'll have that back in. I'm going to send this along, and we'll send it, and I will stop sharing and hand it off to the next person.
Yeah, so these are the assessments for Jenny, and there are 2 of them.
Well, there's that first one.
Yeah,
So that's section A.
That did pretty well. And then this one.
Hey, that went over too. Yeah. Hey, presto. Okay, so we got, I think that's section J. So section A and J may have gone over, which would be correct. Section C was the bundle.
So Justin, do you want to try to display the questionnaire response?
Sure, thank you. So here we are, WA Verify Plus again, and I will pull the questionnaire responses for Jenny here. And of course, this would all be authenticated, smart on FHIR or otherwise in the real world, but here we just have our proof of concept. And I see 2 questionnaire responses and can view the detailed resource there and have a look at the source questionnaire as well. And that's that.
Excellent. Thank you. So Kaylin, do you want to display the assessments in the PseudoEHR?
In the PseudoEHR, we can see the questionnaire responses listed on this page. Like we said, there are 2 questionnaire responses. So this is MDS section J. So we can see the fields that were answered in that form. And then we also have the MDS section A, and you can also see these answers here too. So at this point in the scene, I think I can also display the updated medication list for the scene, which are here for Jenny. So at this point, still have the hospital discharge list and the skilled nursing facility administration list and the corresponding medication requests listed here.
A referral to palliative care is made, and her medications are updated as part of that referral. So they reach out to the palliative care team at the cancer treatment center. She is still in the nursing home at this time. Jenny feels much more comfortable and her care continues. Her assessments are repeated in early November, and she demonstrates a marked decline in cognitive function and gait stability as her disease continues to develop. Her care team leverages the healthcare agent designated in Jenny's advanced care planning and portable medical order, her half-brother James, and lets him know that he is needed to inform current and future treatment decisions. Jenny's chemotherapy fails her, and her condition continues to deteriorate through November and December. The skilled nursing facility and palliative care teams work hard to provide Jenny the best care and avoid hospitalization. They work closely with James and provide him with information and support. To make Jenny more comfortable, James decides to engage with a hospice service.
So she's now moving into the palliative care treatment within the SNF. And so we're going to be updating the plan. And earlier she was independent in function, so she's no longer independent in function. We're going to go ahead and delete that strength. And she really no longer prefers to be at home. She realizes her current condition and she's happy where she is. And then she's going to change her goal a little bit as well. So before she wanted to be as independent as possible and be comfortable, it's really still the same, but she really wants to be spiritually and physically comfortable. So I'm going to change that. And let's see, on her assessed needs, again, we're not going to continue this level of PT. So we'll get rid of that. And she has a new need. She's really showing more progressive functional and cognitive decline. So we'll go ahead and add that. And then we'll change her activities just a bit as well. So we're going to actually eliminate her PT and her OT. We'll go ahead and delete those. And we'll add a new activity, which is going to be hospice support for ADL. And let's see, this is going to be active. And the frequency, again, would be daily. So we'll do it once and daily. And I think this is still going to be done by a service. And this is going to be by the SNF. And I'm not going to put any additional costs into that. So let's see, all of that is in, and her risk management. So again, we are actually not going to be engaging with hospice. It's going to be, so instead of PT and OT monitoring, it's going to be hospice that's going to be doing the monitoring. And she really has an additional risk as well, and she has increasing pain. And I'm sure we could do a few more additional things to this as well. Save that plan. So thank you.
All right, thank you. Kaylin, let's show the assessments, the new ones in the PseudoEHR.
So the updated question and responses that we can see previously submitted are listed here. So originally we had 2, as mentioned before, and now we have these 2 that were submitted via Presto. And for this scene, I believe we have some addition of medication list, which is this list here, skilled nursing facility and palliative care administration list. We can also see the corresponding medication requests that will be listed out here. You can see the updated dates. We also have some new observations in the scene that we can see here. We go and look at the observations. The observations are listed here. And then lastly, I'll show the nutrition order and update. There's one added nutrition order here, but we can see previous ones too.
Great. Could you dive into a little bit of those new observations, the functional communication measures?
Yep. So we have our observation collections here. This is for functional communication measure. We'll have these observations here by ICF category, question, and response. And then Looks like we have another one here, but ICF category, question, response, and then some others here.
Thank you. And Justin, did you want to show the questionnaire response generated by Presto?
Yeah. So I will pull the current questionnaire responses, and I may have added these. Let's see. These are the questionnaire responses from the test server.
Thank you very much.
Dave, if you'd like to see the assessment in the
Yes.
comparison model, we can show you that as well if you like.
Yes, that'd be great.
So basically, these are the two cognitive status kind of assessments. So the first one is expression of spoken language. This is the first assessment, and this was done on 10/24, and then the second one was done at 12/29. And what we do is I'll show this instead of breaking out every one of these. You can see it in summary form, so you can see it over time. So that for each one of the questions, you can see how they performed over time for that particular assessment. So you can see that over time, she's actually decreasing her competency there. And the same is true for receiving the spoken message. And again, you can see that this is basically, decreasing over time as she progresses in her cancer. Again, these particular assessments didn't happen to have any of the links that can show trending, but in other kinds of assessments we've done in the past, that would be included in the summary note. Okay.
All right, great. Thank you. Yeah, and this is one of the key things of taking the questionnaire response and breaking them up into individual PACIO observations and collections so that you can do that kind of longitudinal analysis to show how a patient is doing on a particular question, which is more difficult to do when you're just dealing with a questionnaire response. So great.
On December 28th, Jenny is discharged from the skilled nursing facility to the care of a hospice agency. She remains in the skilled nursing facility for continued day-to-day care while simultaneously receiving expert hospice care, which is allowed under Washington state regulations. Her medications are simplified and become focused entirely on her comfort. Sometime in mid-January 2025, Jenny's symptoms require much more intensive management, and she is moved to inpatient hospice for the last days or hours of her life.
I will hand it off to Kaylin to demo the transitions of care to the hospice.
All right, so this is PseudoEHR again, so we can look at Jenny's new medication lists that have come through. We have a hospice administration list and a skilled nursing facility discharge list. We can jump to medication requests to see these listed out here by date. Yep, so these are the two transitions of care that we have here. So by the date, discharge summary, by the specific sections, and the provider is listed here. We can show a list of allergies for Jenny Mosley. We have the list of medications prescribed for Jenny Mosley, and we can actually jump to that medication list. We have a list of the conditions and observations, and we can also jump to that. We also have this transition of care looks similarly.
Super. Thank you. So that reaches the conclusion of our scenario. And so thank you, everybody, for participating and putting this together. I think one of the things that really we wanted to kind of show, even though the outcome for the patient is certainly not positive, she ends up passing away. But the real key thing is all along the way, because we've paid attention to the advanced directives, the medications, and the reconciliation, and we're able to really provide her the best care for her according to her wishes all the way along. And because this information is flowing, the assessments and things like that, the idea is that we are not only providing the care that she wants and what's best for her, but we're also perhaps saving some cost along the way because things don't have to be redone as the patient moves from one facility to another. The way that all of these different pieces are coming together and showing how that information can inform the future care teams as they go through their journey, that can really help provide better care at lower cost. I know, Juby, you were working on a slide.
What we are doing inside through PACIO, but it impacts so many different areas of a patient's journey, because we talked about at home, coming into the hospital, then the nursing home, but the family involvement, others. Then we showed what a nursing home has to do with that MDS. I remember doing that 18, 20 years ago. And that is how nursing home gets paid or extra money or categorize what is happening for the patient. So our action through PACIO and all these other is providing a great deal of efficiency. And I didn't touch the pharmacy. If we look at the drugs and how things are, that's going into a higher rate. But on the simplest actions that we were doing, faster decision making, even the prior authorization or the decision to go get the chemo or go get this test done and then transfer to the nursing home, that inherently saves a lot of money, because if you wait another day, then that's another day inside the hospital that's adding up to maybe another $8,000 or $10,000 a day. If it's inside the Medicare, sometimes if it's in a DRG, maybe it's kind of like all inclusive. It doesn't cost anything until you hit day 28 or 29. But you get the gist. And I estimated very little. So you think about someone in the hospital who has to do some of the extra work, the unit clerk, the nurse who has to do the work. There's this opportunity cost. I mean, we fastened the decision with all the information, how Nancy was able to show the medication, connect the other team members and communicate faster so that everything is connected and it's like cohesive. There's no lag time. You don't have to call somebody, wait for them to call back next day. So that's one day extra the patient stays wherever and all. So that if you can save efficiency there, these things add up. So we see about $2,800 coming through savings. And that's on the lower end. E-post, this is also very minimal. This can actually go up to like $100,000, $200,000 per patient. But episode that Jenny mostly went through this journey with the things that PACIO and the team was able to do, we were able to bring in about $25,000 in cost savings just on Jenny Mosley. And we're not touching the drugs. That's a whole different story. But just on all that whole journey, we can save a lot of money. And the things that we just did really did impact on overall savings. But also at the same time, it reduced the provider burden, because that's one of the things that we're trying to do. It's really exhausting for the providers and connected the dots between the patient, the provider, the hospital, the community. So I just wanted to thank everybody, and I wanted to say we are doing some great work, and I appreciate all the things that we're doing, and thank you guys.
Thank you, Juby. That's great. All right. Well, thank you very, very much, everybody, for all of your work. This is an excellent starting point for showing how all of these things can integrate together and how various FHIR efforts can work together as a system of systems. So thank you very, very much.